Hello, everyone. Welcome to Introduction to Psychology, and we are on our last chapter of the textbook. This is chapter 15, Abnormal Psychology, looking at disorders and treatments. So, after this lecture, my hope is that you'll take away from it to be able to describe as well as evaluate the definition of what mental illness is. You'll be able to discuss the biopsychosocial model of mental illness, looking at the different cultural influences on abnormal behavior. You should be able to provide examples of such. We're going to talk about the DSM-5 and look at the different categories that's listed within it, as well as look at some of the assumptions behind the DSM, which is Diagnostic Statistical Manual, and the categorical approach that is taken for mental illness. So our first objective is going to be defining what is abnormal behavior anyway. The American Psychiatric Association defines mental disorder as a clinically significant disturbance in an individual's cognition, emotion regulation, or behavior that reflects a dysfunction within the psychological, biological, or developmental processes that underlines mental functioning. So basically, it's what's the reasonable definition, but not always an easy one to say. Who gets to decide whether someone has a clinically significant disturbance? Do we let people themselves decide? Or do we always trust what a psychiatrist or a psychologist would decide? Well, what if therapists disagree with one another? Because it do happen. And when we look back in generations of past, people have had many different views on abnormal behavior and the causes. And we look at how the idea of a demon possession, for example, which was more popular in medieval times, but it's still common to this world today. The ancient Greeks talked about how behavior was of four fluids, that being excess of blood would be caused by sanguine or courageous and loving personality, or the excess of phlegm caused phlegmatic or calm type of personality. So there's thinking about too much yellow bile made one chloric, which they felt made someone easily angered. If there was too much black bile made one melancholic or would be otherwise sad. Now, as you see, and we're hearing about so many different types of traditions and myths and folklores and ideals in regards to what abnormal behavior represented and how it represented that. If we take a look at the traditional Chinese philosophy, for example, personality cycles through 5 different stages or elements, just as they were seasons. And then the excessive response, it can cause too much of fear, anger, and so forth. So now what we talk about is the standard view for the day. What abnormal behaviors would result from can be a combination of biological, psychological, as well as social influences. In terms of the biological roots of abnormal behavior would include genetic factors, infectious diseases, if one had poor nutrition, sleep deprivation, drug usage, as well as other type of influences on the brain's functioning. In terms of the psychological factors, then we're looking at reactions to how people deal with stressful situations, such as when people who were physically or sexually abused during childhood, they're more than likely, it was a predictor that they would have psychological issues in adulthood. Also, we want to look at how behavior must be understood and within its social and cultural context. Behavior is considered acceptable in one society, but it might be labeled abnormal in another. And a big example of that would be if someone's crying out loudly at a funeral. In some societies, it's acceptable, whereas in others, it's not. We can also look at in terms of behaviors in which here in the Western cultures, we wouldn't believe in doing circumcision on women, but in uh, African continent, there are certain tribes that utilize this and find it acceptable for their society. So, because of this, we learn from our culture what we anticipate to be normal. We also learn that there are options for behaving abnormally. Now, in speaking about how we come about finding out what a mental disorder would be, the latest edition of the Diagnostic and Statistical Manual, which is the DSM-5, lists possible diagnoses as well as the criteria for identifying each of them. And this is the tool that is kind of like our Bible within psychology of what we would utilize in terms of working toward diagnosis. Now, this table here on the slide is giving you a list of the categories that would be for psychological disorders in the DSM-5. And as you can see listed, we have neurodevelopmental disorders, the bipolar and related disorders. We have anxiety disorders, trauma-related disorders, somatic symptom disorders, elimination disorders, sexual dysfunctions, impulse control, neurocognitive disorders, the paraphilias, the schizophrenia spectrum. We have depressive disorders, obsessive-compulsive disorders, dissociative disorders, eating disorders, sleep-wake disorders, gender dysphoria. We have substance abuse and addictions, personality disorders, as well as others that are not listed in a category of itself, but might still have to be recognized due to the symptomology. Now, the DSM has helped to standardize psychiatric diagnosis so that we as psychologists, we are able to use the terms like depression and schizophrenia, and in doing so in more consistency and consistent ways that we would have done otherwise. But what I also want to let you know is that the approach assumes that every disorder would fit into one category or another, and that each troubled person can receive a single unambiguous diagnosis. Well, the fact really remains is that there are many troubled people that could fit into several types of diagnoses that's part or in none of at all in a perfect order. So when someone's suffering from depression or mania, anxiety or substance abuse conduct disorder, OCD or schizophrenia, chances are that it can be a 50-50 possibility that you're suffering from at least one or more of these others as well, at least to a mild degree. So a person might fit mainly into one diagnosis now, but they actually can also fit into another one later on down the line. Additionally, there are different type of disorders that can show overlapping symptoms. And when we're speaking about the genealogy, the genes that increase the risk for any of the disorder also can increase the risk for others. During highly stressful experience like a death of a loved one, it can trigger the onset of depression, or it might trigger anxiety, or it can even be a catalyst towards someone who may have a predisposition for schizophrenia. Even when psychology or therapists agree on a single diagnosis, that diagnosis doesn't necessarily can be the reliable point or way for treatment. We might utilize antidepressant drugs for people with disorders that have something other than depression, for example. We might even use antipsychotic drugs sometimes to help with relieve non-psychotic disorders like depression. I don't know if you've ever seen some of the different commercials that the pharmaceutical companies would present, in which they actually present a antipsychotic that would go along utilizing it with an antidepressant to help someone who is in major form or persistent depression. So there's a lot of psychologists who are kind of dissatisfied with the DSM approach, I being one of them, because it's not always a cookie cutter approach. Okay. Um, we would rather be able to rate each client's problems along dimensions rather than sticking them in a category per se, uh, and giving them a label. So one way of looking at it is, instead of having one diagnosis, a therapist might have a rating scale, so to speak, like what you see below. Another criticism about the DSM labels would be that there are too many conditions considered to be mental illnesses. So if you seek help to increase enjoyment of sex, then that means your sexual interest or arousal is a disorder, or hypoactive sexual desire is a disorder. A woman that has premenstrual distress gets the diagnosis of a premenstrual dysphoric disorder. So you see where I'm going. Not everything should be labeled a disorder, but still, you know, it's something that happens. If you get only 7 hours of sleep per night, but you feel sleepy during the day, you may have trouble feeling fully awake, and after a sudden awakening, they might say that you have hypersomnolence. Oh, goodness, excuse me. That came out funny. Hypersomnolence disorder. Some of these words I can't even pronounce. That's how bad it could be. However, the list goes on, and there are 100 different possibilities. Surveys have been able to demonstrate almost half the people in the United States can qualify for at least one of these DSM diagnoses in terms of mental illness at some time in their life. So we have to really be careful, bottom line is. Although this is a guide and this is our Bible, it's still something that we really want to be careful on wanting to label somebody with a mental illness, because we also understand the stigmas that can be attached to that. Uh, so let's keep moving. One of the most common disorders would be within the anxiety disorders, mood disorders like depression. And then we could talk about the impulse control disorders like ADHD. Then another common disorders would be found within substance abuse. So these are some of those that we have high frequencies and see a lot of diagnosis within these different type of disorders. So now we'll start looking specifically at some of the disorders. Particularly in this module, we'll look at anxiety disorders as well as obsessive compulsive disorder. Once we get through this module, you should be able to discuss what's generalized anxiety disorder as well as panic disorder. You'll be able to discuss how learned avoidance responses can be so resistant to extinction in terms of learning. We'll look at the theoretical constructs in terms of classical conditioning and how it might explain the onsets of different phobias. We'll also take time to evaluate classical conditioning's explanation in phobias, being able to look at how the observations have been cited and why it's not an easy task at hand. Then we'll move toward obsessive compulsive disorder, or what everybody knows as OCD, and be able to explain how the phobias and obsessive compulsive disorders might interact with one another. All right, so now we're going to take a look at disorders that have extreme levels of anxiety. People that have been diagnosed with generalized anxiety disorder, they have been where they experience extreme anxiety throughout the day. And particularly, it happens when there are actual dangers that are low. It's like it's not necessarily they're in an extremely bad situation, but they'll feel like they are. So understand that generalized anxiety disorder is where people will have these exaggerated levels of worry. Um, and because of this, it can move toward other things such as panic disorder. Now, panic disorder is going to be characterized by episodes of anxiety that can be debilitating for a person. And they might experience high heart rate, rapid breathing, And there's been several studies that demonstrated a genetic contribution in regards to panic disorder. But no single gene has a strong influence to say that it's the case. There's been many individuals with panic disorder that would also develop other type of phobias, such as agoraphobia. And agoraphobia is that excessive fear of being around and out in open public places, in which they'll want to spend their entire time and lives inside, away from everyone and everything. You also have the sociophobia, and that's a more of one of those severe levels of avoidance from other people, as well as doing anything in public. So you see, they kind of ride between each other, don't they? However, usual treatment generally will focus on more like psychoeducation, that being teaching the client or patient to be able to control their breathing and learning to react when one of these episodes erupts. So if we're able to control the stress and teach a person appropriate coping strategies, it's helpful for them in terms of their panic disorder. Now, just started talking about phobias from the last slide, but avoidance behaviors are highly resistant to existence, okay? That being, for example, say you believe that Friday the 13th, if you're superstitious like I am, is a very dangerous time. You'll become more cautious on that day more than other days. If nothing goes wrong, then you'll see the caution was successful, which is reinforcing your initial superstition in the first place. However, that that it's right that you didn't step on the cracked lines, that you didn't walk under a ladder on that day, that a black cat didn't cross you. Everything will fortify the reasons why you need to be that cautious. However, if something do happen, if there is such a misfortune, then that'll also reinforce and enable that belief that Friday is the 13th is definitely a dangerous time. As long as you continue to have these avoidance behaviors, you'll never really learn whether or not it was quite useful. And when we speak about superstitions, and they can fall sometimes within a phobia depending on the individual. I can recall a time my mother, we were at McDonald's and we were having a meal, and one of the workers, they were sweeping the floor and cleaning up, and she saw that person coming, and she warned them. She said, look, please go around and sweep everywhere else, and when we leave you can come and sweep where we're at. Well, unfortunately, the worker kind of ignored her instructions, and they came close and actually brushed the broom against my mother's foot. Needless to say, my mother had a fit. She snatched the broom from the person, turned it around to where the bristles was up toward her face, pulled out and spit dead on the broom. Boom. Needless to say, that worker was shocked and speechless. They really couldn't say anything because she said, I told you don't come near me with that broom. Well, what reinforces this for her was an incident that occurred in her childhood, in which during a visit, her uncle had visited her family, and they were there hanging around, and he accidentally hit his foot up against the broom. Nobody swept him, but his foot touched the broom. And my grandmother said, you need to spit on that broom before something happened to you. And, well, my uncle was like, I don't believe in superstitions. That's just a crock of bull. I'm not doing it. Well, what coincided with it that day was he got arrested later on that day. So once my mother heard that, she felt foolhardy that it was true, that this is something that it has been proven. As in her regard, she would say that's a scientific proof. And from that day on, you could never tell my mother anything otherwise. And in learning that, although I'm a psychologist and I know differences and I understand folklore and I understand superstition, these different superstitions that my mother believed in was ingrained in me. So I am one of those individuals who would have a fit if a broom swept over my foot. And even if I accidentally hit my foot as I'm sweeping, I roll it up and I on that broom. So is it logical? No, it's a superstition. But superstitions can have that much influence on how a person might live, and it can develop into phobias and interfere with your daily functioning. So, just as a recap, these avoidance type behaviors, they're extremely resistant to extinction. Once it's ingrained and embedded, it's generally going to be there, and it'll take a lot of work otherwise. Because, like I said, even though I am educated and I'm a psychologist and I know better, but I will still follow some of these superstitions to this very day. And if I don't, I do find that my level of anxieties will rise. Okay? So a phobia is that fear that interferes with our daily functioning, and it's learned. The majority of it's learned, and it's usually due through observation, like my mom with her uncle, with me with my mother, passed on. So it's in other experiences might drive a person to have that. Another phobia I have though is with snakes. We'll talk later about that, but hopefully that gives a good description about phobia. All right. You thought I was finished, didn't you? Well, I'm not. We're going to talk a little bit more about phobias because perhaps you may have some phobias. But these are more of those common type phobias people demonstrate and have, in which common objects of phobias that like public places, public speaking, fear of heights, air travel, can't get into an elevator, um, and I mentioned snakes, remember, or other dangerous animals. These are just some types that people are fear of. When we talk about social phobia, though, remember this is an avoidance of contact with unfamiliar people. This is another one that's really common. People might have phobias of blood. They might have fears of lightning storms. Hello, I'm one of those individuals. I tried my best not to be outside at that time. When I was in graduate school and I lived in Springfield, Missouri, attending graduate school there, they had some vicious activity when it came to storms. And no, you couldn't get me to step outside during that time. And I'll never forget one time we had a storm while I was at school. And I was at that time getting a lift from one of my cohort, and it was lightning and thundering. I would not leave that building. I was like, I'm gonna sleep here tonight. They wanted, because we had night classes. That building didn't get to close until about midnight because that's when the storm stopped. And my friend, he's a true friend. Uh, we're still in touch with each other almost 20 years later. But he stayed. He didn't leave. He stayed because I was like, I'll catch a cab. Don't worry about me. But he stayed. The faculty member that was there, they stayed, and we chatted until the storm went away. So it can be quite serious. And as you can see, it didn't only impact me, that particular situation, it impacted others as well. So that's something you want to be aware of. But overall, when we're talking about this, people are going to be more likely to develop these phobias of certain objects, like me with the snakes, than others. Uh, some may have phobias and problems with cars, for example. The most common objects of phobias, they're where they've menaced humans throughout our history. Things that poses real dangers that are difficult to predict or control are what we generally will have those few safe experiences with them. So, for example, another thing I have a big phobia about, to which it drives my family crazy: water bugs. I hate them. They fly, they're huge. I can't stand when you have to kill them because that squish makes me feel horrible inside. So you're learning about Dr. Kearns-Cooper because I'm sharing all my crazy phobias. But usually, during rainy season and rainy weather here in the South, you're going to find one or two sneaks into the house. And when it happens, I tend to run and get my son or my husband and beg them, please kill it. I don't want to even do it. I am proud to say, though, this year at least, it's gotten to where that I've had to do the killing of the water bugs because they haven't, they're ignoring me now. Or they're asleep when I see them, because as y'all know, I'm the vampire. I sleep in the day and not at night. So I'll give you one example and then I'm gonna move on. But I think it was like maybe 2 weeks ago, last really rainy days we had, one got in the house, and I mean, it was like that big. Let me put my fingers up close. Yeah, like that. Okay, huge. And it was on my right here. I'm in my living room, and it was right over there. And I saw it from the corner of my eye as I was watching TV because it was not far from the television. And then it took flight. My husband was in the other chair. I grabbed my jacket. The jacket was laying on the side of the chair and flipped it. Well, needless to say, I got him. And the rest was history. He was gone. But my husband, he laughed for days after that. He said, we just got to keep your jacket there, because you can get them quick instead of with the fly swatters. Couldn't get to the fly swatter quick enough. The only thing that was available was my jacket. So, with that all being said, these are common type of issues that a lot of people deal with. And for some, it can be really severe. So how do we treat these phobias? I gave you an example of one in which I had to face it and deal with it because sometimes they're not available. People are not available to help. But a common type of therapy for phobia is what we call exposure therapy. Okay, it's also known as a systematic desensitization. So the more I do it, the easier it's supposed to get. Although I try my best not to do it as often as if I don't have to. If one of my family members are there, I just rather. The biggest problem for me is I hate to hear that. Another thing, in terms of when we're speaking about this, people tend to relax while they're being gradually exposed to that object or the phobia. So if it's like I was seeing them every day, those water bugs, the notion would be that it wouldn't be bad as always. And like I mentioned, we've had a rainy year, so a lot of them have been sneaking in. It was like I've gotten where I've had my husband put them little flaps under our doors so that can try to help the situation because I'm just not with it. Those are horrible things. But I've done more of getting rid of them myself this year than I have in the past. Uh, when people like with snakes, for example, that's another phobia of mine. And the thing is, growing up, my brothers had snakes as pets. And when I was young, I wasn't afraid of it. So I don't know what truly occurred that would make me afraid of them now as an adult, something must have happened. Maybe that boa constrictor squeezed me more than it should have as a child. I can't recall for sure. But suppose you have a snake phobia, okay, arachnophobia, if you want to know what it's truly called. Um, and what we would do is start exposing you first to pictures of snakes. Um, where it's in a more safe environment and a place where actually snakes wouldn't be normally. Um, that's how I might start with a person who's having a phobia and afraid of, have fears of snakes. Then it might be where we'll start drawing out snakes and gradually work up to looking at first a black and white photo, then move up into a color photo. Then we might actually go to a zoo so that you can see, or a pet shop, so that you can be up in front of a real snake. Now, initially, a person that has severe levels of phobia towards snakes would be terrified at any of that at first. But that gradual exposure, in that terms, that autonomic nervous system really will not be able to deal with the permanent type of panic. But as we gradually do it, you start calming more. That feeling of fight or flight from the sympathetic nervous system, it's not going to kick in as much as the flight mode might hit. Instead, you'll come calmer. The parasympathetic will kick in better and easier, and you just start to realize this is really not that bad at all. You may go from here I am, I'm not far from this horrible snake, but I'm not having a heart attack. I'm not dying. I can still breathe. Those would be things that we would be working toward when we're using exposure therapy. Now, although exposure therapy is really a highly effective treatment protocol, this is one of those more temporarily types. So sometimes the phobia can return depending on the situation. Exposure therapy is extinction of the original type of learning, but extinction is merely going to be a suppression of it, of the original learning, and it really may not erase it. We definitely might have some spontaneous recovery occurring, okay? Uh, and that's when that original learned response returns. Now, this is one of those disorders that a lot of people feel that they have this disorder. Let me first say, before I start talking about the disorder itself, there will be times when you hear about disorders and you're going to hear about the symptoms, and you might find that you may feel you have some of these traits. It doesn't mean you have the disorder. There is a series of different things that we look at, different within the categories, different levels. And that's why you would want to have psychological evaluations that will provide a true determination of whether one possesses a disorder. So with that being said, because obsessive-compulsive disorder is one of those disorders a lot of people automatically take claim to when they necessarily don't have the true diagnosis. However, people with obsessive-compulsive disorder, they do have these distressing thoughts or impulses. And a lot of them will also have these repetitive type behaviors in which obsessions, their obsessions would actually start leading to more compulsions. Think of it as itching sensations that leads to scratching. Like when you first get an itch, you feel the tingling, and that tingling will keep going until finally you find yourself just grabbing and scratching. Okay? Another example might be someone can be obsessed about dirt and disease, and that develops into compulsions of continual cleaning as well as washing. We're in a real difficult time for people who I call germaphobes, okay, that has phobia about germs, because we're living with the COVID-19 crisis and pandemic. Individuals who deal with this and who are actually obsessive compulsive disorder with that, dealing with the avoidance of germs will be within extreme anxiety levels right now. So what they may have been doing that can be found to be dysfunctional before might be even more exaggerated due to the serious risk we're having. So it can be really hard for individuals with this form of mental illness. And just because though you might find yourself, because I have issues with my health, so therefore germs is a problem for me. I get extremely excessive. I don't want to be touched. Constant cleaning. I try to stay away from everybody. But it doesn't mean I have obsessive compulsive disorder. One aspect of it doesn't make it a full blown disorder, but I do have some compulsives. Okay, but your most common compulsions would be in terms of cleaning, and you'll be wanting to always check. You ever find yourself wanting to go back and check to see if you turned off the stove, or did you uh, lock the door? Well, a person that has obsessive compulsive disorder might do it 20 times. They might have checked it, go back, check it, go back. And there's a ritualistic number that they'll have attached for it to say that it would absolutely be safe. Because most of us will go back and check. Oh, did I really turn off that oven? Let me go look. We do that. But I wouldn't have to do it 20 times to feel finally that, yes, the oven is off. A person with obsessive compulsive disorder would continuously check several times, even though each time they've done it demonstrated that they actually took care of it the first time around. Another one that would be a common type thing would be counting one's steps, counting particular objects, or anything for that matter. OCD is also, in terms of compulsions, a person who's a hoarder. That's common for this particular disorder as well. All right, so we were talking about people that have obsessive compulsive disorder, particularly those who have the compulsive, like the compulsive checkers I just spoke about. They really don't believe their thought process in terms of memory. They don't trust themselves, and this distrust of their memory makes them go back and check over and over and over again. Therapy that best supports this evidence would be the exposure therapy, and with inclusion of response prevention. That being, a person would simply be prevented from being able to perform those rituals that they like to do so much. So, for example, say a person is where things have to be in a special order, lined up in a specific way. Um, and anything out of order would actually raise anxiety. Well, with exposure therapy in terms of our response system, I may move something that they generally would fix. I had a client who had obsessive compulsive disorder, and they every time came to meet with me would automatically line up my desk in a certain way. Automatically, not asking if it's okay to do it. They just felt that my stapler needed to be one place. My stapler needed to be near my phone. Next to the stapler should be my two pens or whatever amount of pens, and then an eraser. I would purposely start moving one of the items out of their reach, away from them. And for that person, it really got to them initially. It was like they thought life was over. They was like, Dr. Kearns-Cooper, is it okay if I go get? No, I was like, no, it's not okay. And we would work through it and talk about why it was inappropriate for them to rearrange my desk in the first place. Because actually, I do have my fun where I like to see things in certain order, but not to the point where I get really upset if it's not. I just find that I allow people to do things, and then when they're gone, I fix it back to the way I like it. But that doesn't mean I have OCD, okay? But we all have these traits. But a person like the person I was working with, for them, it made them really upset to see things out of order. If I moved, for example, the eraser, and I just put the eraser to the other side of us, and they're talking, and it was where they're watching, and I was like, I just want you to see that, you're okay. That it's all right that the eraser's on the other side of the desk and not where you need it to be. So that's one way that we try to work best with them. Where was I? I got really into that. But the thought about exposure therapy is really going to be the most successful procedure that we have available right now. And the sad thing is, it can be really ineffective. For people with OCD, the dislike of the idea of stopping the rituals is just as devastating. And a lot of times what happens is they'll stop treatment. Thankfully for my client, they didn't stop. It did take us at least 6 months before they no longer talked about those items on my desk. We were able to get into other things that were more important for them to be able to work on than the items on my desk. But for those who cannot get past it, the treatment's ineffective because they'll basically get up, walk out without getting any real benefits. It'll have a lot of people respond well to cognitive intervention that also will help them to reinterpret the thoughts and images that's going on at that time. And there's going to be some times in which we have to include pharmaceuticals, psychopharmaceuticals, such as antidepressants, that would help with this disorder. All right, so this next module, we're going to take a look at substance-related disorders, okay? We're going to look at substance dependence or addictions. We're going to talk about the difficulties in listing these substances and why they are or they're not addictive. Look at some of the explanations regarding addictions. And then hopefully we'll be able to have you, when we're finished, be able to have you identify how younger people might have more of a risk in terms of alcohol abuse, and then look at the treatments for alcoholism as well as opiate abuse. So first we're going to look at substance dependence or addictions. People who find it difficult or impossible to be able to stop using a substance are considered to be dependent on or addicted to that substance. Almost all addictive drugs increases the release of dopamine in a small brain area that's called the nucleus accumbens, which is apparently going to be a critical area in regards to one's attention and reinforcement. However, be careful in assuming that the release of dopamine in the nucleus accumbens will cause addiction. An example the textbook provides is talking about compulsive gambling as well as video game playing. Much of this is in common with drug addictions. After they become addictive, the release of dopamine within the nucleus accumbens, but it really is misleading to say that because they became addicted because it released the dopamine itself. So it's hard for us to be able to put limitations on or say what can or what cannot be an addictive substance. There are people who show addictions to gambling or to video games, like we mentioned, which is really not a substance. It's an activity, correct? And then there's going to be some who manage, to wind up with an addiction on something that we need to survive, like water. Have you ever heard of polydipsia? That's an addiction to water. So when we think about what are the motives for the initial use of a substance, like if people start using alcohol or they start smoking cigarettes, and why is it becomes different from addiction? Now, you have people who drink for pleasure, who just like to do it every once in a while, who tend to just do it to relax, or, when they're feeling a little anxious, they might have a sip of wine. But an addiction is really more insistent. Addicted drug users, they get much less pleasure from it than they would at the very beginning. They'll continue to want to have that drug even when they know the drug is really not good for them. Let's say smoking, for example. The majority of smokers who've been smoking for years, they know this is not good for them. So they want to quit, and they may attempt to try. But that nicotine captures the nicotine receptors that we have within our brain structures already, those neurotransmitters, and it locks on. And that feeling is something that becomes a necessity for a person. Even though they know it's not good for them, it's not something that is easily able to break. So why do addictive behaviors continue with that intensity? That's what we have to ask. Another reason that I might mention is people have these addictions to escape unpleasant feelings. When they're abstaining from a drug, it leads to withdrawal. Withdrawal symptoms that's from prolonged alcoholism, for example, that includes becoming nauseous, sweating, being sleep deprived. You might even show psychotic features of having hallucinations, as well as even going into having seizures. When we talk about opiate drugs, withdrawal symptoms that can include anxiety, restlessness. You might be vomiting, have diarrhea, or be sweating. These consistent type things, like cigarette smokers, we experience those unpleasant mood swings that they want to try to stay away from. But it happens. And then because of that, people start avoiding trying to stop, because that unpleasant things that occur when you try to leave it alone intensifies, and nobody wants to feel bad. You also have to think about the person who might take drugs to relieve those withdrawal symptoms, learns its power to be able to relieve the distress, and then begins to use it to relieve other kinds of displeasure or issues. People might try to quit drugs, they often relapse because of periods of financial or social difficulties. Neuroscientists have demonstrated that when an addictive behavior bombards the nucleus of humans, and there's massive amounts of dopamine being shot in there. And this is stimulating those synaptic changes that are the same type that occurs during our learning process. So an example here is after repeated cocaine use, the synapses, they're learning to respond strongly to that cocaine and those reminders of the cocaine, but it decreases the response to other reinforcers. So what happens is that craving for cocaine will decrease the interest to any other type of activity. Cocaine use then becomes the only effective way to be able to produce those synaptic activities that's normally going to be associated with one's pleasure. Now, we already started talking about alcohol, but understand, alcoholism is that habitual overuse of alcohol. Treating alcoholism is really hard, and the success is really low. When people try to quit, not everybody can. They often do have relapses. You need to know, though, that there is a genetic predisposition that contributes to most of these early onsets of alcoholism. If a person's late onset alcoholism, it's usually because it's been gradual over the years, and it affects just as many women as it would men. But it's going to be less severe, and it often happens in people with no family history of alcohol. Now, early onset of alcohol, that's more fast and rapid. That's starting around age 20, 25. It's usually occurring more in men than it is in women, and usually going to be more severe and shows the strongest genetic basis. Okay? Although there are many genes that will contribute in some ways, some small ways, only one is really known to produce those effects large enough to be able to produce the results that are easily replicated. That gene affects the liver's ability to metabolize alcohol. The liver converts alcohol into a toxic substance, acetylcholine, and then uses another enzyme to convert the acetylcholine into harmless acetic acid. However, people vary with their genes for the second enzyme. Those who form the gene would be slow to convert acetylcholine into acetic acid. So if they drink much of it at a time, it accumulates the acetylcholine. They start to feel sick, and then they're experiencing what is called a hangover, major hangover. Alcoholism really depends on the environment. Prevalence for alcoholism and other kinds of substance abuse varies along different cultures as well as subcultures. So an example being alcoholism is going to be considered more prevalent in the Irish culture, which have a high tolerance for heavy drinking, than it would for those that are Jewish or Italians, or who emphasizes drinking in moderation. The incident rates of alcoholism is going to be greater than average among people who grew up in families marked by alcoholism or conflicts, hostility, as well as inadequate parental supervision. So we know that not only is there a genetic predisposition that can be involved with alcoholism, we also know that the environment plays a role in whether a person becomes an alcoholic or not. And continuing talking about predispositions, one way to predict which young people will later become heavy drinkers is being able to measure the amount of the body sway after drinking, or simply inquiring people to report how many drinks they need to experience various effects of the alcohol. So, of course, research has been done, and people who report experiencing little effect from a moderate amount of alcohol are more likely than average to become heavier drinkers. Their thresholds is where they could have had, 3 drinks and nothing. Okay? But of all the people who try to quit alcohol or other drugs on their own, it's estimated that 10 to 20% are able to succeed, though many of them will quit and have a fast relapse before eventually being truly successful. On the other hand, many other people find that they can't quit a substance or the substance abuse problem on their own. And they hit what we call rock bottom, or hit the bottom. And when they're hitting rock bottom, it's because they discover that they have damaged their health. They've damaged the chance of maintaining or keeping their jobs. They might have lost relationships, families, or friends. So at that point, this is when they realize, I need help. I'm losing everything. Okay? At that point, options are going to include things like Alcohol Anonymous, AA, or using Antabuse, which is a drug that will make you throw up as soon as you take it. Okay? As well as instituting a contingency management plan. You may deal with and be able to get self-help groups like AA that's going to help you with the most common treatment for alcoholism, and that's here in the U.S. AA is like one of the standards, in which, of course, people go for these meetings, and it's Alcohol Anonymous because there you don't have to worry about people judging you, but trying to work through, just like you are, any type of addictions. There'll be some alcoholics that are going to be treated with Antabuse, and that's what I mentioned, is where it's a prescription drug, and it's going to make you feel sick and want to throw up and nauseous all the time if you drink alcohol. Rewarding people for abstaining from drugs can sometimes be effective. Alcohol Anonymous, for example, When a person reaches a certain goal, like for example, when you have been able to go a full day without having a drink, you would get what they have as chips, and that marks your accomplishment. And it's starting with, you may get from one day, you might get another one for the week. It might go to then getting a 6 month, 1 year sobriety. So sometimes being able to abstain, people get reinforced of continuing because of these type of rewards. Now, when we're talking about opioid and opiate dependence, this has generally had a more rapid onset than alcohol or tobacco dependence ever had. The following video is going to describe it, and then I'll continue with the lecture, but I wanted to share this video first.
Where does pain relief end and opioid addiction begin?
We began teaching people that pain was bad and that we can get rid of it, and you have a right to not be in pain. This was what drove a whole new wave of addiction, because those initial small studies were simply wrong.
Small studies from big pharmaceutical companies that claimed high-powered painkillers were safe and that there was minimal risk of becoming addicted, leading to a wave of over-treating chronic pain.
But what's happening is many people are experiencing profound side effects.
Those include addiction, serious respiratory complications, limited concentration over time, fatigue, and the chance for increased feelings of depression. And over time, patients may start to feel trapped by the pills they were once given to make them feel better.
They are incredibly valuable medications, but only for short-term and for targeted purposes.
Typically safe short-term opioid uses include surgical patients and trauma patients. Also, opioids can be safely used to treat terminal palliative care patients suffering severe pain and cancer patients with pain that won't respond to other medications. Even then, it's important to know we're living in a whole new world of addiction.
The wealthy, the working classes, daughters, sons, mothers, fathers, grandparents, who are all becoming addicted. And it has had a profound impact on our society.
All right, so you heard a lot already. We've heard a lot in the news and in the media, and how this has actually become an epidemic in the United States as well. Some people who are trying to quit heroin or other opiates, they kind of turn to self-help groups, contingency management, and other treatments. Therapists, they emphasize in the importance of being able to identify locations and situations in which someone would have the greatest cravings for it. And then they'll help them to try to minimize the exposures to those particular situations. And then there's those who can't quit the opioids. Research has demonstrated that they've sought to find a less dangerous substitute that would be able to satisfy the craving for those opioids. The drug methadone has been one of those, sometimes offered to substitute an opioid. It's chemically similar to morphine and heroin, and methadone can be addictive as well, but it's also considered a safer addiction than it would be heroin or opioid usage. And there are some who criticize that and whether or not methadone should be provided, because, as said, it's replacing one addictive type of drug to another.
Where does pain relief end
All right, so right now this slide is just giving you a comparison of methadone and morphine, and it's comparing the two. And when methadone is taken as a pill, it's going to enter your bloodstream gradually and it'll depart gradually. If morphine or heroin is taken as a pill, much of it is going to be digested without reaching the brain. Thus, uh, methadone does not produce, that rush that people would normally get, that's going to be associated with injected opioids. And so it's not really strongly going to interfere with the important behaviors like being able to maintain your job. Methadone does satisfy cravings and help blocks the heroin or morphine from reaching those same receptors. But methadone does not eliminate the addiction itself. People who try to reduce their use of methadone generally have reported that their drug craving still comes back in return. All right, so we have now gone through substance abuse. We're going to now take a glance and look at mood disorders, schizophrenia, and autism. And after this module, my hope is that you take away from it being able to describe some of the symptomology as well as causes of major depression. We're going to look at the advantages and disadvantages for treatments in regards to depression. We'll then take a look at bipolar disorders as well as major depression. We'll talk about schizophrenia and the symptomology behind that, as well as the genetic background for schizophrenia. Then we're going to look also into the neurodevelopmental hypothesis in terms of schizophrenia and be able to, hopefully, you'll know the different evidence that supports it. Last but not least, in terms of schizophrenia, we'll look at the different therapies that's available for it. That being psychotherapy as well as psychopharmacology. And then we'll talk about the autistic spectrum disorders to wrap up this module. Okay, so let's take a look at depression. People with depression find themselves having very little interest or pleasure with life, or they have trouble sleeping. Sadness is a major characteristic for depression, but it's that lack of happiness that is even more prominent within depression. Approximately 20% of the U.S. Adults at some point or another in their lives would be classified as depressed. Women experience depression more than men do, and whites will experience major depression more than blacks. Now, in terms of depression, it occurs within episodes. Typically, people have an episode of depression that can last a few months, and it's going to be sometimes years, but years is actually rare. They'll eventually recover. However, the depression can return. Later episodes tend to be briefer, but they're more frequent when it happens. So an intense stressful event like a divorce or the loss of someone that's close can trigger that first episode of depression, but those later episodes, they might occur with less provocation, being that, say, just a sad situation might happen, or if you didn't do well on an exam, because of the initial depression that you may have had, that relapse for depression is greater, even though it's not as the trigger was not as a serious event. In a related type of condition, seasonal affective disorder, or SAD, here people repeatedly will become depressed because of the season of the year. It could be a particular season. Most effective treatment for seasonal affective disorder would be exposure to bright lights for a few hours each day. Now, I think I mentioned to the class earlier that I had the opportunity to work in Alaska for a couple of years, almost 3 years actually. And during that time, a lot of my cases in terms of depression was during the winter months. Now you have to understand something. Winters in southeast Alaska are extremely long in terms of our day and night ratios. In the wintertime, we only get between 8 to 10 hours of daylight. The rest of the time is dark. So, for example, I can get to work at 8 a.m. and it's still dark when I get to work. Daylight really doesn't show up until about 9:30, 10 a.m. And when I leave, it's dark already again because the sun will set around 4 or 5 p.m. So you can imagine when you're working, and if you work on the inside, you don't have an opportunity to step outside, you never see daylight. So for individuals that suffer from seasonal affective disorder, this is a condition that can really hit a person hard, okay? Where in the reverse, spring and summertime is a better time for these individuals that suffer from seasonal affective disorder because those times reverse itself. But mind you, there are some individuals that struggle with the seasons in terms of having too much light as well. It's more difficult to go to sleep when the sun doesn't set till 2 a.m. and then it rises right back up again about 7 a.m. So yeah, seasonal affective disorder is something that can impact people, and it's more common than people can realize, particularly depending on the region you live. If you're in a region that's like Alaska, then it's really the prevalence rates are higher. All right, so let's talk about environmental and genetic influences in terms of depression. The role of genetics in regards to depression is really unclear still, so to speak. There are studies that's been conducted with twins and relatives of patients that have been diagnosed with depression that indicates a moderate degree of hereditability. And then there's been extensive research on chromosomes on thousands of people, and it failed to really identify a specific gene with a major effect on depression. Perhaps there's a lot of uncommon genes that's capable of leading to depression, or perhaps there might be an explanation that would lie within epigenetics instead of looking at chromosomal changes. There's a lot of people with depression that have relatives who have been diagnosed with depression. And then there's also relatives with other issues such as substance abuse. There might be some that have antisocial personality disorder. There may be some that have attention deficit disorders, bulimia, nervosa, somebody suffering with migraine headaches, asthma, arthritis, as well as other different diseases and issues. Many people recover from depression and then they can later develop anxiety disorders, substance abuse, or any kind of eating disorder. So, I mean, there's comorbidity that might exist. Pretty much, basically, when we're talking about genes or even other factors that can be a predisposition toward depression, there's an increased vulnerability to a lot of the different mental illness disorders, not just depression alone. All right, so let's look at some treatment modalities in terms of major depression. Common treatments for depression generally would be the inclusion of antidepressant medications as well as psychotherapy. There are three common classifications for antidepressants, and those are being tricyclics, SSRIs or serotonin reuptake inhibitors, and the monooxidase inhibitors. Now, when we talk about tricyclic drugs, these will interfere with the axons being able to reabsorb neurotransmitters, specifically of dopamine, norepinephrine, and serotonin after releasing them. So tricyclics, what it does is it'll prolong the effect of these neurotransmitters at the synapse. Now, when we talk about the selective serotonin reuptake inhibitors, or SSRIs, we're talking about items like Prozac, which is that's the brand name, but the generic name would be fluoxetine. Here, this will have a similar effect, but what it does is it stops the reuptake of serotonin only. The monoamine oxidase inhibitors, or MAOIs, this will block the metabolic breakdown of dopamine and norepinephrine as well as serotonin with the enzyme, the monoamine oxidase. So MAOIs, what that does is it'll increase the effects of the neurotransmitters. Now, in psychiatry, the psychiatrist will seldom prescribe MAOIs, but except for patients who really didn't respond well to the other classifications, the tricyclics or the SSRIs. Now, in terms of antidepressant drugs, it alters the synaptic activity within an hour or two, whereas mood improvement really doesn't start for 2 or 3 weeks after a person starts taking it. Generally speaking, whenever I had clients who would begin an antidepressant regimen, I told them don't start looking for it to give full effect until at least 30 days. Okay? Prolonged use of antidepressants will usually increase the production of a chemical that's called brain-derived neurotrophic factor, or BDNF. And pretty much that's over a period of weeks that leads to the birth of new neurons that's going to be found within the hippocampus. It's going to be expanding of the dendrites as well as improving one's learning abilities. Depression has been associated with impaired learning as well as a decrease, excuse me, a decrease with cell growth in the hippocampus. And these changes in the hippocampus that can be a main reason why antidepressants help, although researchers, they're really not too sure about that. Now, cognitive therapy, this particular therapy focuses on being able to change a person's thoughts as well as encourage more of an active lifestyle. According to Aaron Beck, who's a pioneer in cognitive therapy, he felt that depressed people, they really are guided by thoughts that he called negative cognitive triad of depression. He would a therapist following cognitive therapy would be asking their clients about whether or not they felt deprived or depleted. Do they see the world full of obstacles? Is the future devoid of any kind of hope? And people who have these automatic thoughts, they interpret ambiguous type of situations being a disadvantage to their own. So therapists here would try to overcome these type of thoughts, irrational thoughts, and get clients to reinterpret these events in more positive type of ways. So a therapist might invite the client to take that negative thought and change it by, like a prosecuting attorney would. They would kind of defend what the positive thoughts might be. And then produce counter arguments to whatever negative thought that client was having. So if they were saying, oh, it's just a dreary day, I would say to them, but the sun is shining. What makes it a dreary day? The sun is out beaming. You see what I mean? Okay, so cognitive therapists, they'll encourage people to become more active, meaning take part in more activities that brings them joy or pleasure. For example, I don't know if y'all looked at the home page yet for our Canvas, but I said that I left a message and I also left a video in terms in which asking y'all to still take care of yourselves. This is a holy weekend for some, and regardless of what our religious belief or systems are, we would generally take this time off in recognition to the Holy Weekend. So I promote it and put up for your enjoyment who you may see people that you know, of fellow tigers that were rejoicing and giving praise and singing the gospel. That's activities that I'm speaking about in terms of mentally recharging yourselves. Okay? I also included that you need to be giving yourselves me moments right now. Staying home is not an easy task when you're used to being out and about. You have to give yourself me moments and do things that you enjoy doing. If you like listening to music, bang that stereo. This is the one time I'm going to say let the decibels go up some. Not too far over 90 though, y'all. And don't use your headphones to do that. Let it be out loud. I don't want you going deaf. So I'm trying not to give you these implications that I want you to hurt yourself. I want you to enjoy yourself. Enjoy your life and know that this too shall pass. Okay? So anyway, that's my soapbox. I'm getting off it. Let me get back to this topic. Because depression happens in episodes, a lot of people that do not get treatment, they actually will start to improve over time. And then there'll be some that it'll happen like this. You ever have your own pity party? That's what I call it. There's times I can get really depressed. And I have what I call my 24-hour pity party. I allow myself to feel depressed for the 24 hours. Then I reflect on what it was that was making me depressed, and then I work on getting rid of that feeling. So, we all go through it from time to time again. I can imagine right now so many people feeling anxious, feeling scared, getting depressed over this situation. It doesn't mean that that's going to stay forever. And with cognitive therapy, the goal is to take the negativity, and by all means, COVID-19 is one of the most horrific things that you're dealing with in your life thus far, and see that it's something that you can actually overcome if you do the things you need to do to take care of yourselves, to take care of your family, take care of your community. Stay at home is an active practice to help avoid COVID-19. All right, so given that, we've had research demonstrate that placebo actually helped and increased the recovery rate for some individuals, just because they expected to see some type of improvement. If we look at the results a few months after the onset of depression for some people, about 1/3 of the patients, they improve without having any kind of treatment or placebo at all. And about half of those improve with either antidepressant drugs or psychotherapy. There was another half that, with the addition of these type of therapies, there was also improvement. People with mild to moderate depression, they'll respond as well as to placebos as they would to the antipsychotic drugs. And then the drugs would be better than placebos for people who have severe levels of depression. And that's mainly because these people really don't respond well to the placebos. One example that I think I shared again, and I'm going to share it anyway. If you heard it, you're going to hear it again. But I talked about how when I was young, within your age range, between 20 and 24, I stayed sick a lot with gastric issues and migraine headaches. And went to my doctor. My doctor gave me a prescription, and at that time, I was one of those trustworthy people. Always trust what your doctor says and do what your doctor says. And I'm taking this medication, and I'm like, oh my God, it's not working for me. What's wrong? And I had a friend who was a nurse, and she was like one day, she said, let me see your prescription. Let me see what they're giving you. So I hand her the bottle. She bust out laughing. She thought it was hilarious. She said, your doctor done gave you a placebo. He must think you're a hypochondriac. Well, needless to say, I was extremely upset because here a whole 3 or 4 weeks were going by, and I'm taking these daily as prescribed, and nothing was happening. I was still getting migraine headaches. I was still dealing with gastric issues, and I felt miserable. Well, I'll let you know, I did go see my physician and cussed him out and told him how dare he. And needless to say, I changed positions because he thought a placebo was going to do something because he thought this was all in my head. Anyway, I had to give y'all some little anecdotes to break up the monotony of this lecture, but it's also an example of what and why doctors would do that, because there are some who have demonstrated through research that because they're just taking something, period, psychologically speaking, it helps them to improve. Their brain says, I'm getting something, so it's time to activate and let's get these neurons firing up. In my case, it wasn't that. There was other underlying issues. It wasn't depression for me. It was actual physical, and not psychological, but physical problems that I was contending with at that time. All right. Next slide. So antidepressant drugs, they're going to usually show benefits a little faster than them placebos would. Okay? They are less expensive than some of other type of treatments that's out there. It's easier to be able to take a pill, rather than spend an hour with a therapist. But, because I'm not a big proponent on immediately giving antidepressants to a person. Because they can produce some unpleasant side effects, like you might get dry mouth, or you'll have problems with urination. You might have your blood pressure increase. Some different people, depending on if they're diabetic, it has an impact on that. As a therapist, my goal first, before I offer that's a last resort for me. I first want to see if we can work through whatever the issues are that's making the person depressed, okay? Prior to, if they're able to come up with coping skills, being able to resolve their problems without the use of medication, that's what I go for first. Have I ever recommended that a client take antipsychotic? Well, that too, but antidepressant medications? By all means, yes, I have. But many people have found that when they stop taking drugs, once it's been prescribed, that the depression usually returns in a few months. Okay, so there are benefits to it. There, just like there's benefits to psychotherapy, but psychotherapy is usually going to take longer. And the good news, though, is if you do go through psychotherapy, depression tends not to come right back as it would if you just took pills and then stopped. So there are a lot of people who they really didn't respond to the drugs or psychotherapy, though. And when we have individuals like that, what has been offered as a treatment paradigm has been the electroconvulsive therapy, or ECT. That can be an option for some people. ECT has been widely accepted since the 1940s and 50s. Then it fell out of practice in favor because history of abuse was being done with it. Some of these professionals, they get there and they put it in, they would use it for all the wrong reasons. There's been some patients that were subjected to ECT. Okay, so I have to apologize. We got cut off because I clicked the button too soon. But in regards to what I was saying, ECT is something that's acceptably used today. And then finally, other treatments that has been used in terms of depression would be exercise, eating right, and so forth. CBT, actually, cognitive behavioral therapy, is also one of those well-known therapies that's useful for depression. So now we're on topic of bipolar disorder, okay? And I have a video I would like for you to watch. It's given a great explanation, and more or less we're going to talk about the two types. It's going to demonstrate and discuss the two types of bipolar disorder.
Maybe you've heard the term bipolar used to describe someone who's moody, or who has mood swings. But this colloquial use of the term is really different from bipolar disorder. Bipolar disorder, which used to be called manic depression, is a serious mental illness that causes a person to have dramatic shifts in emotions, mood, and energy levels, moving from extreme lows to extreme highs. But these shifts don't happen moment to moment. They usually happen over several days or weeks. There are a few different types of bipolar disorders, but there are some common features. First, the low moods are identical to those in a related disorder, major depressive disorder, also known as unipolar depression. Individuals with this can feel hopeless and discouraged, lack energy and mental focus, and can have physical symptoms like eating and sleeping too much or too little. But along with these lows, the thing that sets bipolar disorders apart from unipolar depression is that individuals can have periods of high moods, which are called manic episodes or hypomanic episodes, depending on their level of severity. In a manic state, people can feel energetic, overly happy or optimistic, even euphoric with really high self-esteem. And on the surface, these might seem like really positive characteristics, but when someone's in a full manic episode, these symptoms can reach a dangerous extreme. A person experiencing mania might invest all of their money in a risky business venture, or they might behave recklessly. Individuals might have pressured speech, where they talk constantly at a rapid-fire pace, or they might have racing thoughts and might feel wired, as if they don't need sleep. Manic episodes can also include delusions of grandeur, like for example, they might believe that they're on a personal mission from God, or that they have some supernatural power. And finally, they might make poor decisions without any regard for later consequences. One way to understand these swings is by charting them on a graph. So let's say the y-axis is mood, with mania and depression being on the far end of the axis, and the x-axis is time. The average healthy individual might have normal ups and downs throughout their life, and they might even have some pretty serious lows once in a while, maybe after losing a job or moving to a new place and feeling lonely. An individual with unipolar depression, though, might have normal highs, but they'll probably also have some crushing lows that last for a long period of time and might not even have an obvious trigger. Now, for the bipolar disorders, the first one is called bipolar 1. And these are people that have some major lows that last at least 2 weeks, and then some major highs that last at least a week or require hospitalization. That said, untreated manic episodes can last as long as 3 to 6 months. And even though depression is seen in most cases, it's not actually required for a diagnosis. The second one is called bipolar 2, and this is when a person experiences similar lows and has additional highs called hypomania, which are less severe manic episodes than we see in bipolar 1. To qualify for a diagnosis, these hypomanic states need to last for at least 4 days. Once again, though, these symptoms generally last a few weeks to a few months. Alright, and the third one's called cyclothymia, or sometimes cyclothymic disorder. And these people have milder lows as well as milder highs, or hypomania like you see in bipolar 2. And they cycle back and forth between these two over a period lasting at least 2 years. Sometimes people with bipolar disorder can show other, less common symptoms as well. For example, having what are referred to as mixed episodes, experiencing symptoms of both depression and mania at the same time. Another symptom they might have is rapid cycling, which describes a situation where a person has 4 or more episodes of depression or mania within a given year. Like most mental health conditions, the exact underlying cause of bipolar disorder isn't known, and there's no single bipolar gene that's been identified, but it's thought that there are genetic and environmental factors that play a part. For example, one interesting clue is that people with family members who have bipolar disorders are 10 times more likely to have it themselves. Another clue is that some drugs and medications can trigger manic episodes, like selective serotonin reuptake inhibitors, or SSRIs. It's also worth mentioning that people with bipolar disorder often have other disorders like anxiety disorders, substance abuse disorders, ADHD, and personality disorders as well, making diagnosis and treatment a real challenge. Even though there's no cure for bipolar disorder, identifying and treating individuals is really important, since there's a real danger that the person could harm themselves or even commit suicide. One of the oldest treatments is also one of the most effective treatments, and that's lithium salts. Lithium acts as a mood stabilizer, smoothing out the highs and the lows that they experience. That said, it's much better at treating manic rather than depressive episodes, and so individuals who take it often have to take other medications as well, which can be problematic since some antidepressants, like SSRIs, can trigger manic episodes in people that are predisposed to them. Other treatment options include antipsychotics, anticonvulsants, and benzodiazepines. But many of these, including lithium, have side effects that can be severe and lead to non-adherence, which can be dangerous for the person. Now, unlike certain disorders like unipolar depression, psychological interventions like talk therapy or cognitive behavioral therapy are not particularly effective in treating the manic episodes of bipolar disorder. Having said that, they can still be very helpful tools to help someone with bipolar disorder in general, especially after a manic episode is ended. They can also help the person handle stressful situations that might otherwise lead to a manic episode, thereby helping to prevent a potential manic episode in the first place. Alright, so super fast recap. Bipolar disorder is a mental disorder characterized by depression, periods of lowered mood, as well as mania, periods of a heightened mood.
All right. So I think that gave a great explanation. One thing I did want to address when the video spoke about suicidal tendencies for a person who's exhibiting bipolar disorder, the one thing that we have to be careful of is when a person is leaving the depressive cycle and moving into that manic phase. Generally speaking, it's during that time that we would have to be more concerned with suicidal ideations and attempts, because they're feeling strong enough, so to speak, or more apt to be able to do it during that manic phase than they would be during the depressive stage. Okay, so now we're going to look at schizophrenia. There's a diagnosis of schizophrenia would apply if someone whose daily functioning has deteriorated so much so from such symptoms like hallucinations, delusions, disorganized speech, as well as thought, movement disorder. There might be loss of emotional responses as well as social behaviors. The symptoms have to include at least one of the first three that I mentioned, that being hallucinations, delusions, as well as disorganized speech. And then there has to also be at least two of the five of the symptomologies overall before we can actually diagnose someone with having schizophrenia. Now, the following I'm going to stop in between and I'll start discussing schizophrenia some more. But to give you an idea of what type of auditory hallucinations might happen to a person who has been diagnosed with schizophrenia, I have this little audio video that gives you a clear idea of what might be going on. So we'll play that and then we'll move on.
Jump now. Jump in front of the car. Go on. Do it. No, don't. Corporate coffee futures and professional design future concepts that have professional living and function, relatively independent and wealth generation for entertainment. I have no function for communication. Independent and wealth generation for entertainment. I have no function for communication and investment. Coffee futures at 23% investment. I have to have quoted shipper effect style. Corporate coffee futures and professional design future concepts that have professional living and function.
Why are you ignoring me? Hello? You're disgusting. Very.
Okay, so imagine listening to something like that in your mind all day long. Hallucinations are those perceptions that really do not correspond to anything that is within reality, like those voices that they hear, but no one else hears it. The voices, they might be speaking nonsense, or it can be directed toward a person to have them do something, give them commands. People will sometimes think that the voices are real, and sometimes they know that voices are not real, but yet sometimes they're not sure when it's real or when it isn't. So in terms of hallucinations, there are several types. There's the auditory, which is what you just experienced, and that's the most common form that we find within schizophrenia. But you also have visual hallucinations. You may also have, and that's where you're seeing something where nobody else sees it. Then there is the tactile hallucinations. Tactile hallucinations is when somebody's feeling something that's not there. They might say they feel a spider or a bug boring into them. Those are those type of hallucinations that can be experienced. But again, auditory hallucinations are usually going to be the more common type of symptom that we might find in someone with schizophrenia. Now, besides the hallucinations, there's also delusions. And a delusion is that belief that someone holds really strongly despite evidence against it. An example can be how someone will feel that they are being followed when they're not, or say that they're feeling that everybody that's in a group is against them when they're not. That's that feeling of persecution. A delusion of persecution would be that belief that there are enemies that's persecuting them. So a delusion of grandeur, though, now this is a belief where the person will feel extremely important, and they would probably feel that there's a special messenger from God, that they might be on a mission for God, for example. And then there's a delusion of reference. Now, delusions of reference is those tendencies to take out all sorts of messages and internalize it, taking it as it's for them personally. And I'll give you a great example of a delusion, if I haven't shared this already. When I worked at Mississippi State Hospital, there was one patient that we had, and no matter what, when this patient saw me, they would be ready to attack and hurt me, particularly when there wasn't medicated with psychotropic medications. And the reason why is he believed that I was trying to take his husband. He literally felt that. Now here's the thing, particularly during stressful or crisis situations, you really do not want to try to dissuade a person by saying that the delusion is not real. It will agitate that client, that patient. So rather than me saying, this is a delusion, you don't even have a husband, I wouldn't say those type of things. Instead, what I did was, because at that time I hadn't yet remarried, so I wore no rings, I went out and brought a wedding band. And I wore the wedding band. I cut pictures out of a magazine. And on a good day when he was lucid, I said, I have got married and this is my husband, and showed him a picture of some fictitious character that I made up by using a picture from a magazine. And it sufficed for him. And I said, see, so there's no way I could be after your husband because I just got married. I'm in love. I'm happy, and I forgot even what the name I made up for the husband. But um, as he got on his medication, he got better. The delusions they kind of dissipated, and we were able to finally to chat and work together without me having to worry about him attacking me. Now, unfortunately, though, he did get better well enough to go back home, and I hadn't seen him for years. And when I was working in the crisis centers in the Delta, lo and behold, guess who came in because they had been off their medication? And he once again was actively psychotic. And I expressed to the staff, because I knew if he was actively psychotic, once he sees me, even though it had been like 5, 6 years, he was going to come right at me. And I explained to them, he is not to see me. I mean, until we had him, he had to be on a part of the ward where I wouldn't go in. Well, they forgot to let me know. I expressed to them I wanted to know his every whereabouts so that I can avoid those areas, so not to agitate them. And of course, they didn't tell me when they were going out to take them out for lunch. So as they're going back to the ward, I was heading to my office, and lo and behold, he saw me. Let's just say I was good at running at that point during that time, and I was able to run into my office and close the door before he got to me, because guaranteed he saw me, and the delusion once again was in his mind that I was attempting to take his husband. So it's real for a person, and the magnitude. Think about when you know something is right for you, how passionate you might become. Well, a delusion is just that for that person. They feel it just as much as anybody with of real issues or real tasks. So the main thing I want you to take from that discussion is understand the power of those delusions, um, and you don't want to negate someone or make them feel invalid or make them feel like you think they're a liar. You want to be able to help them gain insight. So rather than say, no, that's just a delusion, you might pose questions that will allow them to think, well, what if that isn't real? You see what I'm saying? But anyway, many people with schizophrenia, they're going to show various type of problems in terms of their communication. That being, it might sound illogical, nothing's going to be making sense, it'll be incoherent, it could be distracted, or they'll have what we call tangential or circumstantial type of speech. Tangential speech meaning they're jumping from one topic to another topic. Circumstantial speech is when they're going to go and they talk around everything and go into all these different things just to come back to the main point of the matter. So with that tangential speech, again, it's like they start speaking and then they quickly forgetting what they're saying, so they start trying something else to say. Now understand, not all people with schizophrenia will have any type of intellectual challenges, but there may be some impairments, and there's various kinds. There might be issues with the attention as well as their working memory. So those are characteristics that we have to look for in terms of symptoms. Another characteristic will be the thoughts of a person with schizophrenia is going to be with abstract concepts. How they interpret proverbs, for example, it's going to be more literal than what we would. And for example, if you say can't cry over spilt milk, they might ask, well, the milk did spill, so why wouldn't you cry about that? So you want to understand that they are quite literal in their thinking at that point. So the main things that I pointed out is those symptoms that we are looking for, they have to demonstrate one of the first three, which are hallucinations, delusions, or the disorganized speech and thought processes. And remember that hallucinations are those perceptions that really do not correspond with anything in reality, and that the most common form will be auditory, but there's also visual as well as tactile hallucinations. And then again, the delusion is that belief that's going to be strongly held despite any kind of evidence that it's not real. And you do not want to just negate what that person's thinking or feeling about it. All right. Now, let's look at some of the stats in terms of schizophrenia. Worldwide, at least 1 to 4 people per capita of 1,000 will develop schizophrenia in some time of their life. Schizophrenia is most frequently going to be diagnosed within younger adults, and that's within their ages of 18 to 20, in their 20s. Sometimes it can be during adolescence. It's going to be more common in men than it would be in women, and that's the ratio would be around 7 to 5, where on average it's going to be more severe though within men. In terms of women, women generally will demonstrate symptoms of schizophrenia more toward their 30s rather than their early 20s. It's not impossible for women to show it in their 20s, but we've seen it more in their 30s and as they're older than they have than they're younger. Schizophrenia is going to be more common among people who grew up in urban areas like big cities rather than those in rural areas or smaller towns. But it still, again, does happen. But the prevalence rates are much higher in urban areas. There's been a lot of evidence that indicated that it could be possibly inherited and that there's a predisposition for schizophrenia. Research has demonstrated that the relatives of someone with schizophrenia has demonstrated an increased probability of someone in that family line developing schizophrenia. Now, there is a hypothesis that's been generated in regards to schizophrenia that results within changes in any of a large number of genes. Okay, so many researchers, they feel that schizophrenia will originate from abnormal brain development that's going to be before around the time of birth due to their genetic background or prenatal environment. Early abnormal development would leave a person vulnerable to further deterioration as they get older and move toward adulthood. Okay, So that neurodevelopmental hypothesis is talking about how schizophrenia would originate from those nervous system impairments that happen at birth or early childhood that emanates as they get older. It might lie dormant, but then become active as they move toward adulthood. Now, in regards to brain abnormalities, brain scans have indicated that people that's been diagnosed with schizophrenia, on average, shows a decrease in gray matter within several areas of the brain, and they also have what is considered to be slightly more enlarged cerebral ventricles, those fluid-filled cavities that's in the brain. Most people with schizophrenia also would demonstrate and show smaller than average neurons as well as fewer than average synapses, particularly within the prefrontal cortex. However, these results really are interpreted cautiously. There's a lot of people with schizophrenia that have substance abuse issues, and it might impair their brain functioning. It can shrink their dendrites as well as other issues in the brain. Drugs help to alleviate schizophrenia by blocking dopamine synapses that came. It was a rough one to get out that time. However, with antipsychotic drugs, it's been able to produce side effects that's actually quite unpleasant for a person with schizophrenia. Specifically speaking, is what we call tardive dyskinesia. So with tardive dyskinesia, it's where they might start showing shakes, having issues with their hands and their mobile functionings. They're not able to keep stable. So that's one of those side effects that can be present. Now, speaking about psychotropic drugs, there's atypical, or what we also consider to be second generation antipsychotic drugs that helps to relieve schizophrenia, and it has less risk to having the side effects of tardive dyskinesia. But with those atypical antipsychotic drugs, there are side effects of their own. So, and it can be of several things. Depending on some of these antipsychotic drugs, we have to be careful in terms of it increasing glucose levels that can lead to diabetes and other type of things. So to give you a long story short, of course, the benefits, we also have the risk with the side effects, but we have to figure out what would be good for that patient when they are being provided with psychotropic drugs. Okay, so now we're going to move toward autistic spectrum disorder. I have another video clip that I'm going to ask you to watch, and then I will go into it further or give a synopsis of what the video describes.
Even though everyone develops at slightly different paces, almost everyone hits the same general developmental milestones and learns the same sets of skills at about the same time, more or less. These are things like language and communication, socializing, cognitive skills like problem solving, and physical milestones like walking, crawling, and fine motor skills, all of which progress as the brain develops. If one of these doesn't develop as scheduled, depending on the severity, it may be described as a type of neurodevelopmental disorder, neuro referring to the brain. Especially when certain skills related to socializing and communicating don't proceed as normally, it can result in isolation, which is where the name autism originated, since auto means self. So autism refers to a condition where somebody might be removed from social interaction and communication, leaving them alone or isolated. Before 2013, the Diagnostic and Statistical Manual for Mental Disorders, the 4th edition, or the DSM-4, described autism as one of several pervasive developmental disorders, which also includes Asperger's syndrome, childhood disintegrative disorder, and those not otherwise specified, or PDD and OS. Asperger's syndrome was used for children that appeared to have characteristics of autism, like difficulties with social interactions or nonverbal communication, but don't generally have significant delays in language or cognitive development, and therefore Asperger's syndrome was sometimes referred to as a high-functioning form of autism. Childhood disintegrative disorder was used to describe late onset of developmental delays. So these children develop normally for their age, but then they seem to lose the acquired social and communication skills sometime between age 2 and 10. Pervasive developmental disorder, not otherwise specified, is essentially a catch-all category in which patients meet some, but not all features of autism, Asperger's syndrome, or childhood disintegrative disorder. Researchers found, however, that separate diagnoses of these pervasive developmental disorders weren't consistent across different clinics, since they tend to have very similar signs and symptoms. As of 2013, the DSM-5, a new revised edition, removed these terms and replaced them with Autism Spectrum Disorder, or ASD, which encompasses all of the previous pervasive developmental disorders, but uses a scale, or a spectrum, that differentiates based on the severity of two major areas: social communication and interaction deficits, and restrictive or repetitive behavior, interests, and activities. For the social and communication area, there are 4 subcategories that clinicians look for deficits. The first is social reciprocity, which refers to how children respond or reciprocate in social interactions. So like how the behavior of one person influences the other, and vice versa. An example of impairment in this area might be referring to being alone and not taking a role in social games. A second area of potential deficit is joint attention, which is the state of wanting to share an interest with someone else. So it's like, hey, check out this awesome thing I found. So an example of impairment in this area might be a child not sharing their interests or amusement in an object with their parent. Next, there's nonverbal communication, which refers to difficulties either using nonverbal communication themselves or interpreting nonverbal cues from someone else. So maybe the child won't put their arms out when they want to be picked up, or maybe they won't be able to tell when a parent's upset, even if the parent's frowning and crossing their arms. The last subcategory of communication deficits is in social relationships. So children have trouble developing and maintaining relationships. So maybe the child has a hard time making friends, or they're able to make friends, but their behavior tends to drive the friends away. The other major area is called restrictive and repetitive behaviors, and this category is pretty broad and can include a whole bunch of behaviors, some being more well-known or characterized than others, like lining up toys in a ritualistic sort of way, or flapping one's hands, or imitating words or phrases. The child might be fixed on certain routines, like taking the same route every day to school, or they might have restricted patterns of interest, like having a very specific and in-depth knowledge of the Titanic, or vacuum cleaners. Children with autism spectrum disorder might exhibit one or more of these deficits, and vary in how severe the deficit is. With that in mind, it's important to remember that each child with autism spectrum disorder is going to have a different spectrum of symptoms and deficits. Typically, clinicians will try to observe these behaviors in a child, looking for these possible deficits. Since these behaviors are often more well known by the child's caretakers than they are by the clinicians, like their parents or their teachers, a meaningful diagnosis of autism spectrum disorder relies heavily on listening to what others are observing at home or in school. They might be given severity scores in each area, which can help determine how much support the child is going to need. For example, a severity level 1 would indicate the child needs some support. For social communication, they might speak in full sentences and engage in communication, but normal back and forth conversation with others just doesn't seem to work. For repetitive and restricted behaviors, they might have difficulty switching between activities. On the other side of the spectrum, a level 3 severity means the child needs very substantial support, and on the social communication side, they might display very few words of intelligible speech and rarely initiate an interaction with others. For repetitive behaviors, they might be extremely resistant to change, and their behaviors seriously interfere with their daily life. It's thought that using this scale of symptoms, as opposed to differentiating between pervasive developmental disorders, will help give a more accurate and medically useful way to diagnose individuals. For example, those with what was previously described as Asperger's syndrome would likely fall closer to severity level 1 than severity level 3. Generally speaking, autism spectrum disorder is thought to have a genetic cause, which ultimately affects brain development, specifically areas that affect social and communication behaviors. Which genes or combination of genes that are affected in autism spectrum disorder, though, is still very much a mystery. In addition, there are a bunch of environmental triggers that have to be explored, but at the moment there are no clear risk factors that have been identified. With that said, there is also no cure for autism spectrum disorder, and treatment or management has to be specifically and carefully tailored to each child. And this includes things like specialized education programs and behavior therapy that all seek to maximize quality of life and functional independence. Alright, as a quick recap, autism is a developmental disorder where an individual has difficulty with social interactions and communication, often leaving them socially isolated. The disorder is along a spectrum of communication and interaction deficits, as well as restrictive or repetitive behavior, interests, and activities. A diagnosis of autism spectrum disorder requires significant input from caretakers, and management of the disease is highly individualized. Thanks for watching. If you're interested in a deeper dive on this topic, take a look at Asmo.
All right. So just to go ahead and give that recap one more time, autism, the autistic spectrum disorders, this is something that is lifelong. It's not something that can be cured. However, coping strategies and helping individuals within this autistic spectrum disorder is viable and doable. Okay, know that their main issues are dealing with social relationships. There's impaired communication in terms of speech patterns, being able to sustain conversations. They might demonstrate stereotypic type behaviors, particularly that might be repetitive. Some individuals will show repetitive movements. There might be sensitivity, skin sensitivity, textural type of sensitivities, issues with fluctuations within their temperatures. There's times that for some, even the lights can be a factor in regards to how they would be dealing with the environment that can be quite sensitive. The causes, there's a genetic link as well as some prenatal predispositions that might be involved, but there's no consistency that has been found within research at this point. So we know that there are some neuro issues in terms of autistic spectrum disorder, but it's so vast and long that it's still something that we're still studying and still trying to learn. There are some individuals, myself included, who wasn't happy with the DSM-5 when they joined all of the different categories into one type of spectrum. But it is what it is, and we do utilize this as far as for diagnosing. And just remember that we do it on levels now, and the severity would be more on a level of 3, where not so severe. Those who can communicate, those who demonstrate natural higher functioning as far as their intellect, would be more on a 1, because their issues are demonstrating more of social issues rather than communication styles and issues. So that's autistic spectrum disorder. All right, so now we're going to start talking about treatment modalities in terms of mental illness. We're going to look at the different forms of psychotherapy. We're going to look at the effectiveness that's been demonstrated through research for psychotherapy. We'll talk about how there are some issues and ways that we help clients that's not as expensive as other ways, some methods, like for psychoanalysis, for example, that's an expensive cost, whereas brief therapies might be more inexpensive. We'll look at different methods that helps in terms of prevention for psychological disorders, as well as look at legality issues, particularly the insanity defense, as well as looking at other societal type problems that erupt because of mental illness, like stigmas and such. All right, so psychotherapy is a treatment of psychological disorders with methods that would include personal relationships between a trained therapist or psychologist and with the client. In terms of treatment of mental illness, it's changed a lot since the early 1900s or mid 1900s. This chart on this slide pretty much gives you some of the changes that have occurred. Okay, so if we look at particular facets to therapy, like the first one's talking about payment. Here in the 50s, that would be conducted through either the patient or their family. But now we have it where health insurance would be involved. The kind of therapist that we work with, back in the 50s, it might have been just a psychiatrist dealing with the medical model solely. Now we utilize the biopsychosocial model in terms of incorporating psychiatrists, clinical psychologists, counseling psychologists, social workers. The list can go on. So that shows a demonstration and a change of it. At the time in the 50s, Freud's work was the main catalyst toward working with individuals. So psychoanalysis was the main type of therapy provided at that point, the talk therapy, so to speak. Today, however, we have many different kinds. I mean, there's over 400 types of therapy out there today. But the main thing I want to say to you is that the majority of the type of therapy utilized today are going to be evidence-based treatments. One of the most popular today would be cognitive behavioral therapy, in which we're dealing with irrational thinking, and in which we're looking not only at the thought processes, but we're looking at the actions of the clients as well. The length of treatment has changed greatly. In the 50s, it often took years before we would say that a client was well on their way of being not having mental illness or being able to cope with and strategize. But today, there are few sessions are found to be more effective and necessary. It's not necessary for a person to be in therapy for 5 years. If they're in therapy for 5 years, we found that more or less therapy is ineffective. In terms of talking about diagnosis, now with back in the 50s, it was more considered neurosis or psychosis, and diagnosis really wasn't given out much. It was extremely vague. Today we have many more. It's more clearly defined. We utilize the Diagnostic Statistical Manual, as well as the International Code for Diagnosis, the ICD. And so there's a plethora of ways that we go about evaluating and making a diagnosis prior to just giving out a diagnosis. It's just not fanfare, so to speak. In terms of treatment decisions, that usually was between the therapist and patient in the 50s. Now, though, we have to include what insurers are willing to pay for in our considerations, unfortunately. But also what's not listed on the slide is that we take a more of a multi-treatment, multi-modality type of approach these days, where we'll have treatment teams, interdisciplinary treatment teams that will be associated with that client or patient in coming up with treatment plans. So let's take a closer look at some of the forms of psychotherapy. As I mentioned, Freud was at the forefront, and you had psychoanalysis that then developed into psychodynamics. So the psychodynamic therapies pretty much attempts to understand those conflicting impulses that a person might endure, some of them being individual but not really consciously aware about those, okay? Psychoanalysts, here again, is uncovering the unconscious reasons that would be behind conflicts as well as self-defeating behaviors. And to bring the unconscious to the consciousness pretty much is being done through relying on free associations, interpretation of dream analysis, as well as transference that's going on between the client and the therapist. Now, I mentioned to you one of our more popular, you'll see listed at the bottom of this slide, is cognitive behavior therapy. But that's actually coming from people who started out in behavioral therapies in itself. Behavioral therapists, they assume that abnormal behavior is a learned behavior and it can be unlearned. And they identify behavior that needs to be changed, like being afraid, or having a bad habit like smoking. And then what they do is they start trying to change it through reinforcement strategies, as well as taking the principles of learning and enacting it with their clients. Now, unlike psychoanalysts, they're going to be more interested in about changing the behaviors. They really don't care and think about twice unconscious conflicts or situations or what the meaning of them are. Behavior therapists are going to be more specific in goal setting with their clients, and they're going to use, again, learning techniques that will help clients to achieve those goals. When they're able to set a clear goal, the therapist will help client judge whether the therapy is going to be succeeding by seeing if their behavior actually changed. And they do this through observation, okay? So if a client doesn't show any kind of improvement, pretty much a therapist will now say, okay, that doesn't work, we're going to try this instead. I want you to start doing this, this, and this. They're going to be more directive. With cognitive therapists, here they're trying to identify distressing, irrational thoughts. Like, people don't like me, or my enemies are out to get me, the persecutory thoughts. And then what they do is they'll try to have their clients replace those defeating thinking construct with more favorable, positive views of themselves as well as with the world. Many therapists will now, like I mentioned, they combine the behavior therapy with the cognitive therapy in order to help change people's behaviors by altering how they interpret the situation they're in. That's what cognitive behavior therapy will do, okay? They incorporate both the thought process as well as the client's actions, learned behaviors, and hopefully get it to where it'll change the behavior and the thought process at the same time. And again, today's standards, cognitive behavioral therapy is considered one of the best forms of treatment out there. All right, so let's take a look at some other forms of psychotherapy. The next one would be humanistic. With humanistic, psychologists, they feel that people can actually decide deliberately what kind of person they want to be. And according to humanist therapists, once a person is freed from that feeling of rejection or failure, pretty much they're able to start solving their problems themselves without the help of a therapist. Carl Rogers' version of humanistic therapy is what's called person-centered therapy, or is also considered to be a non-directive or client-centered therapy. And this is when the therapist is going to listen to the client, with total acceptance and what we call unconditional positive regard, meaning that overall people are good, and I'm not gonna judge your actions. I'm here for you. Therapists that's using humanistic psychotherapy, most of the time they're going to be able to paraphrase and clarify what clients have been able to say, conveying that message that I'm trying to be able to understand your experience from your point of view. Meaning, emphasis is not about what I think, it's about what you think, what you feel, and how can I help you to get there better. Some of the traits that humanistic therapists should have, really is a requirement, is that they have to show genuineness, that they have empathy toward a person, that they care, some compassion. And again, here in terms of giving advice or interpreting what's being said is really not the core issue for humanist therapists. And a lot of times a person's problem is really part of the overall disorder, or of a family communication or the expectations. And what kind of distinguish family therapists is that they prefer to be able to talk with two or more members of a family together. That's family systems therapy. Here they're solving most of the problems that requires the family dynamics to try to change, as well as other types of behaviors an individual might possess. Now, there's going to be times when psychotherapy that's given to people in a group format rather than individually. It's often going to have people that have similar issues going on. It might not be the exact, but they'll have similar issues going on. Self-help groups provide sessions that's similar to group therapy, except the major difference is there's no therapist involved. Okay, it's usually a group of people that get together. AA or NA can be one of those self-help type groups. Okay. Now, we have to always ask ourselves as therapists, clinicians, is the psychotherapy that I'm providing to my client actually being effective? Here we're going to see and talk about whether or not the effectiveness is adequate, beneficial, and then we'll look at the different theories and see how it might go. So when we evaluate psychotherapy, we just can't simply compare people who did or did not choose to enter into therapy. Those who sought out help, they might differ from those who may have real severe issues going on in terms of motivation for improvement. Some people want to go into therapy, where there's going to be others who are forced into therapy. In the best studies that's been provided, people who contact the clinic are randomly going to be assigned to receive therapy at once, or they may have to wait till later for therapy. Then a few months later, researchers have been able to evaluate people's improvement, and often by their answers to standardized questionnaires. Most experiments have been able to include only a moderate number of people. So pretty much to draw a conclusion, investigators have used a method called meta-analysis. And that's when you're taking the results of many experiments, weighing out each one in proportion to the number of people who participated, and then determine whether or not overall if there was an average effect. According to the meta-analysis that was pooled results of 475 experiments, the average person that was in therapy demonstrated greater improvement than 80% of similar people who didn't receive any therapy at all. Now, for a variety of disorders that's relating to anxiety or depression, mainstream types of therapy appeared nearly equal in its effectiveness. Later, there's been research that helped to qualify the statement somewhat, being for several types of disorders, cognitive therapy or cognitive behavioral therapy produces a slightly greater reduction of the target symptoms. So you remember when I mentioned how CBT is considered one of the best out there? This is why we would say that, okay? Particularly when we looked at anxiety. But all the common types of treatment would roughly equal less in terms of specific goals, such as the overall quality of life. All right, so I just wanted to point out and look at similarities and differences among the 4 types of psychotherapy that we talked about. That being psychoanalysis and / psychodynamics can be included with that, behavior therapies, cognitive therapies, as well as the humanistic type of therapies. So in our procedures, everybody attempts to develop what we call a therapeutic alliance. That meaning a therapeutic relationship is built in terms of the client-therapist interactions. With terms of talking about the issues openly, you notice that all 4 paradigms do try to talk openly about the problems. Expectations for improvement is by all of us. Commitment to help be an agent of change for the client as well as the therapist, that's everyone. Now, here's where things start showing differences. Those in terms of looking at the unconscious conflicts, that's going to be strictly psychoanalysis or psychodynamics. Goal setting is usually going to be more behavior therapy and cognitive therapy. Emphasizing learning is a behavioral more or less than anything. Reinterpretation of events or situations is more about cognitive therapy, how the thought processes are going into that. Looking at everybody positively, genuinely, empathically is person-centered. That's unconditional positive regard. And then trying to change thinking, that goes under the umbrella of both the psychoanalytic as well as cognitive therapies. So what is the future for psychotherapy in terms of preventive care? Psychologists, particularly community psychologists, are going to try to help people change their environment in order to promote mental health. Prevention is trying to avoid a disorder from the get-go. You want to try to cut it before it even happens. So prevention can take on several different forms. A universal program will target everybody, like anti-smoking campaigns. Right now we're dealing with COVID-19, in which we're trying to have everybody go and do social distancing, appropriate hand hygiene, staying away from large crowds. That's preventative care, okay? That's more universal. A selective program would be more about how people, looking at specific people that would be at risk, like someone who has a family history of a particular disorder like schizophrenia. We would look at the program itself, identify those people during the earlier stages of the disorder, and attempt to stop it before it gets worse. Effective type of prevention programs need careful testing. There are many interventions that sounds like it really is reasonable, but it really doesn't work. One example would be prolonged discussions of a stressful experience shortly after an event are going to more likely to cause than prevent PTSD. Being scared straight interventions tend to increase criminal behavior instead of decrease it. The best type of programs would give people who are participating active practice at those specific behaviors, such as being able to resist peer pressure to risky behaviors. What happens is it's a buildup of a step-by-step from simple skills to more complex skills. And then they'll start working with people at appropriate times within their lives. An example of this would be the AIDS prevention or pregnancy prevention, how it would start at an age when students might start becoming sexually active, and not many years earlier or many years later. Then there's examples of effective prevention programs that would include the following: banning toxins, the sale of lead-based paint, for example. When we know that children that eat those lead flakes, that's how I call it, the chipping of the paint, has demonstrated brain damage. Education to pregnant women about prenatal care. We know how important it is that between the critical periods that we find within the first 2 trimesters, and how there should be care throughout all 3 trimesters in terms of preventing alcohol abuse as well as other drugs during pregnancy, and how when that occurs, there is going to be damage to the brain of the fetus. There might be bacterial as well as viral infections that happen during pregnancy. So prenatal care is extremely important. Legislation in terms of like smoking in public, where it's become pretty much an outlaw of smoking in places like restaurants and businesses and so forth, is where it helps to educate people about the risk of smoking. In terms of improvement in physical health, improving psychological well-being, all of that plays part of the process. It's also these type of example of prevention programs is also can be helpful in terms of people getting jobs. People who lose their jobs can lose self-esteem. They might increase risk of getting depression, or they might get into starting to take drugs. So the goal here would be trying to help people get summer jobs, like how we help adolescents get a summer job, particularly if they're in low-income areas. It would help in terms of decreasing violent crime. It would also help in terms of neighborhood improvements. So these are the type of things we might look at. One more thing and then we'll move on is talking about bullying. A lot of preventive programs have been developed to try to prevent bullying in school. As we know, children who are frequently bullied, they are at increased risk for anxiety, depression, other distresses throughout life, as well as suicide ideations, as well as attempts. So we try our best to create programs that's going to help eliminate and help to build self-esteem, particularly in adolescence. So until the 1950s, a huge number of troubled people, they actually were confined in understaffed, overcrowded state mental institutions that was created by the government. And back in the 50s, hospitals really moved toward deinstitutionalization by removing patients from mental hospitals to be able to give them at least a less restrictive type of care if all possible. And pretty much the hope was that patients would be able to go home, be able to live a normal life as much as possible, while still receiving at least outpatient care within their community mental health centers, which are usually cheaper as well as more effective than those large mental hospitals. However, implementing these good alternative cares really hasn't been easy. The effectiveness hasn't been truly dependable. So we've had it where the courts would rule that a therapist who's convinced that a client is dangerous should warn the endangered person. And then we have to look at in terms of when we talk about the outpatient care, again, I mentioned before about health insurance, and it's kind of difficult for people who doesn't have health insurance. Now, there are many different clinics that's out there, mental health clinics that do offer, if not a fee waiver, they would put it on a fee scale based on how much money that person would have. But it's still something that makes it a little difficult to be able to provide those services. Now, I talked to you just now about how we're obligated. There is what we call the duty to protect. And because of the Tarasoff case, there was a court ruling that a therapist has to reason to believe that a client is dangerous to themselves or to others. We must warn both the person who's dangerous or take steps as far as protecting that person who might be a harm to themselves. Last thing on this slide is talking about the insanity defense. Now, insanity is a legal term. It's not something that we actually use as a psychological or medical term. The most famous definition of insanity would be from the McNaughton rule, and it's to be regarded as insane under the McNaughton rule. People must be so disordered that they do not understand what they are doing. And anyone who tries to prevent the police from detecting a murder or a crime presumably did understand what he or she was doing to be considered not insane. Here in the United States, fewer than 1% of accused felons will plead the insanity plea. And those who do, fewer than 25% are found not guilty. So no more than 0.25% of all defendants that are found not guilty would be by reason of insanity. This is the last slide in the last part of Chapter 15. From here, after you do this and you complete the assignment, go ahead and start reviewing and start reading the chapters over again. As you know, with our final examination that's going to be coming up in the next 2 weeks, you want to have yourself truly prepared. Utilize these video lectures to kind of help remind you, but do understand, although I have gone over the chapters, there's going to be things that I haven't discussed that you'll find inside your chapter. So it's important for you to do the reading. Of course, the final exam will be 100 questions like before. It will be provided in a 24-hour window, like always, and the time limit will be 3 hours. Okay? If you have any questions, send them as you're doing the reading. If something comes up and you're not sure of the answer, or you're struggling to truly comprehend and understand it, jot down your questions, send it to me in the inbox. If it's where you need to have a conference call in regards to it, send me a request. I'll set that up so that we can talk it out, because I want y'all to get good scores here, okay? We're on that final push for the semester. It's coming up fast, so I don't want you to be on the short end of the stick, so to say. On that note, have a great week. I know this is a shorter week because Monday was considered a day off. So after Easter, Monday is a day off for you. This will still be up though on time, but my expectation was that nobody's going to look at it at least till Tuesday. The assignment though will still be due on Friday, and of course part of the review for next week will be getting practice exams to help you through. I'll be also providing an outline of the different chapters, stuff for you to look at, stuff to help you study. On that note, I'm going to stop talking. Y'all have a great week. Stay blessed.